Greetings, everyone, and welcome to the EKG case for the week of October 15th, 2012. This week's case was sent to us by Dr. Anna Holdgate, who is an emergency physician working down at the Liverpool Hospital in Sydney, Australia. So this week's case was sent all the way from down under. This was a 28-week pregnant young woman who presented to the emergency department with palpitations. And as you look at this EKG, there's no surprise why she is palpitating. She's got a really, really fast heart rate. If you map this out, the rate's about 270 beats per minute. That's what the EKG machine is reading as well. And if you use your calipers, you see that this is a regular narrow tachycardia. So that's what we're going to talk about this week. We're going to talk about the differential diagnosis for narrow regular tachycardias. There's really only three. And if you remember these three things, every time you see a narrow regular tachycardia, you're going to nail the diagnosis in more than 90% of cases. Sinus tachycardia, which is obviously the most common thing that we see, supraventricular tachycardia, which includes a few things that we'll talk about, and atrial flutter. Now, some people might put atrial flutter and sinus tach and AFib under the category of supraventricular tachycardia. Technically they are, but we're going to talk about sinus tach, A-flutter, fib as different things. So again, your differential, sinus tach, SVT, and atrial flutter with 2-to-1 conduction. These are the three main causes of narrow regular tachycardia. Now, how do you figure out the difference between these three? Very simple. Your answer lies in looking for P waves, looking at atrial activity. With sinus tachycardia, you've got 1 P for every QRS. Simple enough. With SVT, the P waves are oftentimes not present. They may be buried within the QRS, so you don't see anything, or sometimes they occur just after the QRS complex. A little blip after the QRS complex, we refer to that as retrograde P waves or retrograde atrial activity. And we talked about flutter in detail before, but again, flutter is another type of narrow regular tachycardia, and oftentimes in those inferior leads you see the sawtooth pattern. The P waves or the flutter waves are mapping out at a rate of about 300 beats per minute. And if there's 2-to-1 conduction, you'll have a regular ventricular response with a ventricular rate of about 150 or so. And the pearl that we said last time we talked about flutter in more detail, anytime you see a ventricular rate of 150 plus or minus 20, you always be paranoid and look carefully for flutter in all of your leads. Now, sometimes the purists actually say, well, SVT actually includes a handful of different types of tachydysrhythmias. SVT is a term that includes AV nodal reentry tachycardia, AV reentry tachycardia, atrial tachycardia, non-paroxysmal junctional tachycardia, and AV reciprocating tachycardia, for example, in pre-excitation. And you know what? I like to make things as simple as possible, and I just lump all of them under the term SVT. And the reason I can get away and you can get away with lumping them all is because in the emergency department, generally they tend to all be treated similarly and they all have relatively similar prognoses. The electrophysiologists are usually more interested in distinguishing between these different things because maybe the EP treatment is a little bit different, especially if they're going to be ablated. But from the emergency department standpoint, since we're emergency physicians, we get to lump certain things and just focus on treating them all. And if you just go through the algorithm that we'll talk about in just a moment, pretty much all of these things will be treated successfully. So I don't worry too much about looking at the 12 lead and trying to make this distinction during the emergency department shift. Okay, let's move forward. All right. Now we mentioned there's three possibilities for narrow regular: sinus tach, SVT, and A-flutter. Here's examples of each of them. Very simple. Sinus tach, 1 P wave for every QRS. 1 P wave for every QRS, PQRS, 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 and so on. Very simple. This is the most common tachycardia that we all see in the emergency department. Second, SVT. SVT, usually you don't see P waves with each QRS, or you oftentimes may see these little retrograde P waves. If you look especially at the inferior leads, you can see that there's these little retrograde P waves, these little blips on the T wave. Right after the QRS complex, you see them usually in the inferior leads, okay, and in lead 2, 3, AVF. So when you see that, that's a pretty good sign that you're looking at one of the SVTs that we just talked about that tend to be treated similarly. And then the third narrow regular tachycardia is atrial flutter with 2-to-1 conduction. And you'll notice that in the inferior leads, it kind of looks like a sawtooth pattern, because essentially what you're looking at are inverted P waves. There's a little P wave right there, and then P wave and a P wave and a P wave. Those are inverted flutter waves or inverted atrial beats, and they give the appearance of a sawtooth pattern. We also mentioned before that your money lead, the lead which is generally the best at picking up P waves, is V1, so we're always going to look at V1. You see that right there, there's a flutter wave buried in the T wave. And so don't miss those. If those T waves map out with the P waves, you're looking at atrial flutter. Okay, so simple enough. We've talked about that before. Now, how do you treat SVTs? Okay, actually, you know what? Let's go back to the original EKG just to make sure that everyone's on board with our diagnosis. We got 3 possibilities: sinus tach, SVT, and flutter. So, is this possibly sinus tachycardia? Well, with the rate of 270, you automatically know it can't be sinus tach because nobody runs their sinus rate that fast. But looking carefully for the atrial activity, there's no PQRS, PQRS, PQRS. Could it be flutter? Well, you look carefully in all of the leads, and there's no evidence of atrial activity that's mapping out at a rate of 300 or so. So this is supraventricular tachycardia. Simple enough. All right, let's go back to where we were before, moving back forward. Now, in terms of our treatment algorithm, where were we before? Sorry about this. So in terms of our treatment, here we go. Treatment algorithm. Start with vagal maneuvers. Please don't forget to do vagal maneuvers in SVTs. All right, a lot of people love drugs. They love jumping right to adenosine. It's fast, it's quick, it's dramatic. It makes a patient feel like they're going to die, and then they're saved. But you know what? Most patients really don't like the feeling of adenosine. So do the simple benign thing. Do some vagal maneuvers first. You might knock out or convert the SVT in about a quarter of cases, so why not try it? Have a patient blow vigorously through a thin straw, or have them bear down like they're having a bowel movement. I don't like doing that. That tends to be messy every now and then. Have them do an abdominal crunch. Put your hand on their belly and tell them to tense up their stomach muscles to push back against your hand. Sometimes people talk about carotid sinus massage, and although the usual recommendation is to not do that in patients that are older because they might dislodge a clot and have an anterior circulation stroke. I've never seen or heard of that happen before, but that's what they talk about, and I hope to never see that happen anyway. So there's various vagal maneuvers that you can try. And as you know, people that have SVTs oftentimes will know to do these things before they show up in the ED. So by the time they arrive, I'll just ask them, have you tried some vagal maneuvers? Let's try it once or twice more. And then I move on to adenosine. Now, I do like using adenosine. If the vagal maneuvers don't work, it's fast, it's quick. I always warn the patient ahead of time that they're going to feel awful for about 10 seconds. And I try to tell them that, ma'am, when you feel this way, it means the drug is working. So they almost look forward to it in a strange sense. But it's important to always tell people that they will feel awful. Substernal pressure, shortness of breath, diaphoresis, they'll get really hot. Tell them to expect that sensation, but reassure them that it's only going to last about 5 or 10 seconds and they'll tolerate it well. Well, the adenosine works in about 90% of cases. If that doesn't work, then you can go on to whatever AV nodal blocker you like. Calcium channel blockers, beta blockers, whichever one you want. I like this option here. If their blood pressure is just a little bit low, say 90 or 100, and I want to use a calcium channel blocker because the adenosine didn't work, I oftentimes will give them an amp of calcium gluconate, just 10 cc's of calcium gluconate, and that tends to keep their blood pressure stable while they're getting the calcium channel blockers. There's some older literature that talked about that. People don't really study that much anymore because calcium's cheap, and nobody wants to study cheap drugs. But you can try that, keep that in your back pocket. Or if you don't want to pre-medicate them and you give them calcium channel blocker and they drop their blood pressure, then you give them calcium, and that usually brings the blood pressure back while maintaining the rate effect of the calcium channel blocker. So it's kind of nice. If none of that works, the guidelines talk about using a type 1A medication like amiodarone, but in reality, that's rarely needed. And almost always, if these medications don't work, we just go right to cardioversion, a little propofol or etomidate, and then 50 joules, 100 joules. That works very, very nicely. All right. Now, everyone loves adenosine, so there's some important points to make about adenosine. You always warn the patient of those horrendous side effects they're going to have and reassure them that it's only going to last about 10 seconds. This patient's pregnant, and adenosine is safe in pregnancy. Some guidelines recommend doing cardiotocographic monitoring during the adenosine push. I don't know what you're going to do with that, but just some guidelines suggest it. It's not a requirement, and adenosine is commonly used in pregnancy. I've used it a half dozen times in pregnant patients that get SVTs, and it works very nicely. Patients tolerate it well. Now, a couple other important points. Since adenosine has such a short half-life, you want to get it in there quickly. So it's recommended that you use a proximal IV, not the 27 gauge between the fourth and fifth knuckle. That doesn't work. All right, use an antecubital line or a good, 18, 20 gauge line. Some people even talk about elevating the arm so gravity helps get it back. But I think the most important thing you do is that you take the syringe of adenosine and stick it in the hub of the IV line, and then simultaneously you have a 10 or 20 cc vial or syringe full of saline, and you put that in the hub also, and then immediately you push the adenosine and then push the saline. So it should be push. You should hear the whoosh. If you don't hear the whoosh, you didn't push it in fast enough. And don't just open up the IV line with normal saline. That's not good enough. You've got to use a rapid bolus of normal saline immediately, and I'm emphasizing that, immediately after the adenosine. Very, very rapid bolus of saline has to be shoved in there in order to get the adenosine to the heart as quickly as possible, because it's got a very short half-life, and adenosine will be gone within 5 or 10 seconds. So you got to push it in very, very quickly. All right. Couple other caveats. You can usually start with 6 milligrams of adenosine with your first dose. If that doesn't work, go to 12 milligrams and repeat at 12 milligrams. But if the patient has a central line or a heart transplant, or if they're on carbamazepine or dipyridamole, you can start with 3 milligrams instead of 6 milligrams. It's perfectly reasonable, and if that doesn't work, then you double it to 6. On the other hand, if the patient if the patient's on theophylline or taking large doses of caffeine, which it means most emergency physicians fall into that category, then you need to start with a higher dose. You start with 12 milligrams. If you want to start with 6, fine, but you can start with 12 milligrams in either of those scenarios. All right. The other point that I want to make is that if somebody has active wheezing, reactive airway disease, then if you want, just go right to calcium channel blocker instead. I recommend not using adenosine in patients that have active wheezing, because adenosine may make it worse. So if they have really bad asthma, especially if they have active wheezing, stay away from adenosine. Let's go back to the EKG that we started with. It's narrow, it's irregular. We've already come up with the rhythm of supraventricular tachycardia. Dr. Holdgate, in this particular case, did a Valsalva maneuver for this patient, had the patient blow vigorously through a small straw, and that converted the patient back to sinus rhythm. It worked very, very nicely. So kudos to Dr. Holdgate for going the benign Valsalva route. Now, there's 2 other points that I want to make here before we're done. First thing is that you'll notice that there appears to be electrical alternans, beat-to-beat variation in the size of the QRS complexes in some of the leads. And we typically think of electrical alternans in patients with pericardial effusions. But be aware that SVT is well reported to produce electrical alternans as well. So if you see electrical alternans in the presence of SVT, it means nothing. All right, it's a common finding with SVT, so no big worry. All right, second point that I want to make here is you'll notice that in the lateral leads especially, you've got ST depression. Some people might say, oh my gosh, maybe this person needs a stress test or needs to be worked up for the ST depression. It turns out that when that has been studied, ST depression in the setting of SVT has no clinical significance. They do not need to get a stress test or cath just for that ST depression. ST depression is very common and expected and has no clinical significance in patients with SVT unless after conversion it persists. And you can see that the ST depression went away once they converted. So the ST depression really doesn't mean anything. And actually, one third point that I'll make, Third point, we've talked about ST elevation in AVR as a sign of left main coronary occlusion in patients that are presenting with cardiac ischemic symptoms and sinus rhythm. However, I think I mentioned this on a previous podcast. It's normal in some patients to have ST elevation in AVR in the setting of SVT. So if a patient has ST elevation in AVR in the setting of an SVT, it doesn't mean anything as long as it goes away when they convert back to sinus rhythm. You can see the AVR ST elevation is gone, okay? So when you see ST elevation in AVR, if it's in an SVT patient, it doesn't mean anything, all right? So there's some nice pearls there. SVT is very common in our patient population, and I think we need to know about the proper dosing of medications and also some of those aberrant findings on the SVT. Hope that was helpful, and I look forward to talking to you next week. Bye for now. And again, thanks to Dr. Holdgate for sending us this great 12-lead EKG. Thanks.